All right, we are going to go ahead and get started. Good afternoon and welcome to the HFMA Colorado chapter webinar series. Make sure that you take a second and follow us on our social media pages for information about upcoming events and webinars. We need to take a moment first to recognize our annual business partners. Their support allows us to operate our chapter and bring our members quality education and resources. We hope you'll take a look at them first when your organization needs services or support. A reminder, certification is now included in your membership. Study materials are online and all modules can be completed on demand at a time that's convenient to you. If you've thought about getting certified or are looking for ways to advance your career, contact the chapter to get more information. NASMA CPE credits are available for, are available for this webinar. In order to be eligible, you must complete all 3 polling questions throughout the webinar. Horrible timing, and I think as we all work at home, we've gotten used to these sorts of things happening. I apologize. It's my pleasure today to introduce our speakers. Ben Fee, an attorney who practices exclusively in health law, advising health systems and hospitals on a variety of financial, regulatory, and compliance matters. He regularly advises clients on reimbursement and financial strategies, government reimbursement, and payment matters, the 340B drug discount program, and corporate compliance issues. Ben earned his law degree and master's in health administration from the University of Iowa. We also welcome Lori Wink. Lori assists clients in the analysis of health law matters and regulatory issues, including billing and payment, compliance, and Medicare appeals. Lori is an active member of the Wisconsin chapter of HFMA. Prior to practicing law, Lori was a manager in the audit department of KPMG and was a member of KPMG's healthcare practice group. I will quiet my dog now as we welcome Ben and Lori.
Thank you, Jessica, for those introductions, and I will just try to share my screen here. Make sure I get it going. So hopefully that looks fine, everybody's and I have about 3 or 4 month old Weimaraner at home, so I am very much used to the barking. And fortunately, or fortunately for our office, I'm not allowed to bring him in here. Otherwise, he'd be making a lot more noise than that. So thank you again for that introduction. Thanks everyone for joining us as we for our today's session to talk about federal price transparency, federal hospital price transparency, and the new Colorado price transparency law that just took effect last week. Happy to be here with my colleague, Lori Wink. As Jessica mentioned, we will try to take questions as we go if you want to put those into the chat box. And certainly if we're not able to get to questions throughout the presentation, we will leave a few minutes at the end. And then if we aren't able to get to all of the questions, our contact information is there below, or if you're listening to this on demand and so you're not joining us live, please feel free to reach out if you have any questions about today's topic, and we will get to those questions as we can. So just a quick look at the agenda for today. We are going to start by actually setting the stage a little bit. And when we talk about price transparency in healthcare, that touches on a number of different laws at both the federal and state, and it's an ever expanding area for a number of reasons. And so we're just going to take a few minutes to make sure we understand how today's topics fit within that broader landscape. Then we will spend a few minutes talking about the federal price transparency laws, and specifically most relevant to the new Colorado law, the federal hospital price transparency rule that went into effect at the beginning of last year, so January 1st, 2021. We'll also talk about enforcement and where we are at the federal level with enforcement of that price transparency law, before we then spend the rest of our time really looking at more detail at the new Colorado law and how that relates to everything else that we've talked about up to that point. So setting the stage, as I mentioned, over the past 3 to 5 years, we've really seen a substantial increase in the number of laws at both the state and federal level that attempt to increase the transparency into what items and services in the healthcare industry cost and what their price is for patients. And it really is something that started more at the state level. And for maybe the past 5-10 years, we saw a number of states passing legislation requiring hospitals within those states to post or disclose certain pricing information. But for the most part, those laws were fairly narrowly constructed, including Colorado's law, which I believe was in effect as of about at the beginning of 2018. And then a couple of years ago, we got the new federal hospital price transparency rule. And it really not only, of course, required compliance for all hospitals because it's a federal law, but was much broader in its scope in terms of what was required than really anything we had seen at the state level. And that's the law that we're going to be tying this new Colorado law, or this new Colorado law ties back to. It's that requirement to post, as Lori will talk about in detail, your various charges in a couple of different ways, and most importantly, your payer-specific negotiated rates in a machine readable file, and then in a price estimator tool for the most part. It's that federal law that this new Colorado law ties to. This new Colorado law, what it does is it limits collection actions for hospitals that are not in full compliance with the federal hospital price transparency law. So it prohibits those collection actions, and then it creates a right for patients to sue a hospital in some circumstances if the hospital is not in full compliance with the federal law. Importantly, and I'm going to mention this multiple times through this session today because it's such an important takeaway, it doesn't actually create any new price transparency obligations on providers that you are not already required to meet today. It just increases the penalties for noncompliance. And so again, I've included it as kind of this main takeaway because it is so important. It is the key purpose behind this law as stated in the legislation itself. It increases the penalties for hospitals that are not complying with the federal hospital price transparency law. It doesn't create any new obligations. It just increases the penalties if you're not in compliance. There were already, as Lori and I'll talk about, a number of reasons why hospitals should be complying with the federal law, including the fact that there are civil penalties at the federal level if you're not in compliance. And we'll talk about how that works and the fact that we've already seen some of those. And then beyond that, I know whenever Lori and I have been advising organizations on this issue, there's often been a question about whether or not the hospital should comply or has to comply. And another part of that conversation is certainly not just the financial penalties, but there is a real patient dissatisfier and public relations issue that goes along with a hospital that is failing to comply with a law that is intended to increase transparency to patients. So there were already reasons to comply with this federal law, and now Colorado as a state has really just raised the stakes for noncompliance. So looking at federal price, actually I see our first poll question has come up, and so hopefully you're all seeing that for your continuing education credits here. The first poll question is, the Colorado law creates new price transparency posting requirements. true or false. And I think we're going to leave that up here for a few seconds so folks can get their response in. And so we will just leave that open here for a little while longer before we start getting into, in more detail, the federal hospital price transparency law. And I'll see if we get the results here before we move on. So the results came in, and if you can see that on your screen, we got about 1/3 of folks saying true and 2/3 saying false. And the correct answer is false. And so, although Colorado does have some limited requirements to publicly disclose your pricing information, this new law is all about enforcing or increasing the penalties for not complying with an existing federal law. It's not creating, there are no new requirements for a hospital to post pricing information today or last week that didn't exist 2 months ago. All this law does is increase your penalties, essentially, through giving patients in Colorado the right to sue if you're not in compliance with that federal law. So let's talk about the federal laws in a little bit more detail. And actually, I'm going to start with just mentioning, again, when we talk about price transparency for providers specifically, it's broader than just the state law or the single federal law. Many of you are probably familiar with a new requirement that went into place at the beginning of this year to provide a good faith estimate of expected charges for items and services to patients when those patients either schedule a service or upon request. This was actually a requirement that was part of the No Surprises Act. That is legislation that was included in a huge bill passed at the end of 2020. It was a consolidated appropriations bill, so it was enormous, thousands of pages long. And within it, we had this No Surprises Act, which the primary focus is on limiting providers' ability to balance bill patients in certain circumstances that they called surprise billing. So a couple specific scenarios, but that gets a lot of attention. But within that legislation was also this requirement to provide a good faith estimate of expected charges to patients. And that really has nothing to do with surprise billing. That is 100% a price transparency law. So we just wanted to mention it today because it is important anytime we talk about hospital price transparency to also include the fact that you have to provide these good faith estimates to patients. For now, that only applies to uninsured or self-pay patients, although that will eventually expand to insured patients as well. And so again, we mention it today for a couple reasons. One being that we really shouldn't be talking about hospital price transparency without mentioning that law. And two, because it actually does not directly tie back to the Colorado law. The Colorado law talks about the other major hospital price transparency law that I will now turn it over to Lori to talk about in more detail.
Thanks, Ben. So I'm going to go into a little bit of detail on the hospital price transparency law. And with any law that involves hospitals, you need to first look at the definition of how is a hospital defined. And for purposes of price transparency, it's defined based on hospital licensure. So in other words, if a facility, a healthcare facility, is licensed under state law as a hospital, the price transparency laws apply. So this includes both Medicare certified and non-Medicare certified hospitals. Interestingly, this is not included in the statutes as a Medicare law. It is a public welfare law, so it does incorporate non-Medicare certified hospitals. You also need to consider hospital outpatient departments that are located off campus. If those off-campus locations are operated and included under the hospital's license, the hospital price transparency laws also apply to those locations. And you need to look at the specific state in which you're operating. So for example, I understand that in Colorado, off-campus locations are reported to and included on the hospital license. So in that case, the hospital price transparency laws would apply. But in Wisconsin, for example, off-campus locations are not included on the hospital license. So there is an argument that the hospital price transparency laws would not apply to Wisconsin hospitals. Next, I want to move on to the requirements of hospital price transparency. And there are 2 postings that are required for the price information for price transparency. The first is a machine readable file for all items and services. And the second is a consumer-friendly shoppable services file for 300 common items or a price estimator tool. And we'll talk about both of these in a little bit more detail. But first, I do want to mention that the information must be available on the website for each hospital location, and it must be prominently displayed. And there's a couple concepts that are included in this prominently displayed. First of all, it has to be available without charge and without having to establish an account, a password, or to register. So it has to be readily available. It has to be easy to find on your website. So in other words, you can't go through multiple links, multiple word choices in order to get there. A consumer should be able to easily find your price transparency information. And secondly, or lastly, it has to include a listing of all the hospital locations to which that price transparency information applies. So let's talk a little bit more about the machine readable file. A machine readable file needs to be included on the website for all and each items and service. You need to include the associated codes, the descriptions of the items and services, and the required standard charges. So let's take each one of those in turn. So the associated codes, you can include your CPT codes, the DRG codes, or an account code, something that identifies what item or service you are reporting on for that line. Then you need to include the standard charges. And this is really important for price transparency. It includes all of the following. It includes your gross charges, your discounted cash prices, your payer-specific negotiated charges, and your de-identified minimum and maximum negotiated charge. The one standard charge that we get the most questions about are the negotiated charges, and that is in fact the contract negotiated charge that a hospital negotiated with a third-party payer. So it could be a bundled payment amount, it could be a percentage of charges, in which case you'll take your gross charge multiplied times that percentage, and that'll be your payer-specific negotiated charge. You need to include all 5 of these for each line item. And we'll discuss these in a little bit more detail as we're going through the Q&As, because we do get a lot of questions on that. The next term I want to talk about are items and services and what that includes. That includes individual items and services, which are each item, for example, on your charge master. So if you have a charge master for an aspirin, for example, or if you have a line item for a level 1 room for nursing acuity, that would be an individual item. And service packages that could be provided by the hospital to a patient for which you have an established charge, standard charge. And remember, a standard charge is any one of the 5. So if you have one of the 5, you need to include that item or service in your machine readable file. A service package is an aggregation of individual items and services into a single service for which the hospital has a single standard charge. So for example, that would include if you have common surgery, common procedures or surgeries. If you have an appendectomy, for example, and a payer gives you a standard negotiated charge for an appendectomy, that would be included as a service package on your machine readable file. Your per diem rates for your nursing and your room and board would be included in your DRG payments. One thing I did want to go back to the negotiated charges and also mention, we do get this question if Medicare and Medicaid HMOs are included in the negotiated charges that must be displayed. And if those rates are negotiated with a specific Medicare, Medicaid HMO or managed care organization, those would be included in the negotiated charges that are included on your machine readable file. Next, we're going to go on to the shoppable services. The shoppable services is a consumer-friendly file, so it's supposed to be in plain language for the consumers. And a shoppable service is defined as a service that can be scheduled by a healthcare consumer in advance. So common examples of some shoppable services would be lab services, if you schedule those in advance. Some infusion services for antibiotics, for example, or chemotherapy would be scheduled in advance. Imaging services like a chest x-ray or some surgeries can be scheduled in advance. Those could all be considered shoppable services for this purpose. The standard charges are the same as the machine readable file, except it does not include the gross charges. So you only list the four: the discounted cash price, the negotiated rates, and the minimum and maximum. You need to report 13 common items and services. CMS has chosen 70 of those that you must list, and then you as the hospital get to select the other 230 common items and services so you get to a maximum of 300. If you do not provide the 70 services that were chosen by CMS, you need to at least designate that on your shoppable services list, either by including an NA or providing some kind of description as to why you don't provide those services. I did look recently at some of the shoppable services list for some psychiatric hospitals, and some of those did list a few shoppable services, but then they had a disclaimer as to why they didn't provide 300 shoppable services, including the 70 by CMS, just by way of an example. The other thing to remember about the shoppable services is your primary shoppable services must be grouped with any ancillary service that the hospital customarily provides as part of or in conjunction with the primary service. So going back to surgery as an example, if you have that appendectomy, you're obviously going to have anesthesia services and you're going to have recovery services. So those should all be included in the standard charges that you're posting on the shoppable services. Other ancillary services you want to consider would be lab and radiology and drug therapy, for example. The goal ultimately here is to make it clear to the patient what he or she can expect to pay for the services that they're selecting on the shoppable services list. An alternative to providing that list of shoppable service is the price estimator tool. Next slide, Ben. So I'll just use chest x-ray as an example as we're going through this listing. So the price estimator tool is an online tool that provides real-time, individualized out-of-pocket cost estimates. And it's an estimate based on what the individual would be obligated to pay. So if I, Lori Wink, have United Healthcare as my primary insurance, and I need a chest x-ray. So I'm going to go into the price estimator tool. I'm going to find chest x-ray. And what should come up is a single dollar amount of what I can expect to pay for that chest x-ray. CMS has said that they don't want to see a range of prices. You can add a range in addition to that single dollar amount, but that would be additional information that you're providing to the patient. It's not required, and it cannot be the only source of the price estimate. It should be tailored to the individual circumstances. So in other words, it should be tailored to my insurance plan and my copays and deductibles. And it must reflect the amount that the hospital anticipates will be paid by the individual. So in other words, it's combining the hospital's standard charge information with the individual benefits information to get to that price estimate through that price estimator tool. Interestingly, compared to the shoppable service list and the machine readable, CMS's guidance with respect to the price estimator tool is not as prescriptive, and there's not a lot of guidance out there. So when you go out and you look at the price estimator tools from hospital to hospital, you will see a fair amount of variation as to how it's presented and what information is being asked for. Because of this, CMS is seeking comments on additional requirements with respect to the price estimator tool. So we are continuing to watch the Federal Registers and CMS's website to see what additional information will be forthcoming with respect to the price estimator tool, but we do expect more guidance to try to refine that. With respect to the CMS price estimator tool, next slide, Ben. CMS, not in the most recent rulemaking, but in last year's rulemaking, they did go through, look at some of the price estimator tools, and they have said that the following do not comply with the CMS requirements. The first is an estimated average amount or ranges, and I've explained that ranges are not allowed for the price of the shoppable service based on a broad population of patients. So in other words, if you have an average based on some selection of the hospital of a broad population of patients, that is not acceptable with respect to the price estimator tool. It needs to be refined to any claims data or any information for that specific payer. And CMS is not entirely clear on what they mean by that, but again, it's not as prescriptive as the shoppable services. And they have said in the Federal Register that some claims information is allowed. It is not appropriate if you do not combine the hospital's standard charges with the individual's benefit information from the insurer. So in other words, if you're just reporting the hospital's standard charges without taking into account the individual's benefit information, that's not acceptable for the price estimator tool, and it's not the goal. The goal is to get to the patient what he or she can expect to pay. And finally, if a hospital includes a disclaimer stating that the price is not what the hospital anticipates that the individual will be obligated to pay, that is not compliant with the price estimator tool, because the goal here is to get to the individual what they can expect to pay. So it's actually counter to the whole goal of the price estimator tool. So next I want to move on to some of the frequently asked questions that we get with the price estimator tool. This rule has been out 2 years this coming January. We're still getting questions. Enforcement is still ongoing. So we just wanted to run through some of these questions. And the first question is, does a hospital have to report standard charges for physicians and non-physician practitioners? And the answer is really sometimes. It applies to physicians and non-physician practitioners who are employed by the hospital and for services that are within their scope of employment. So the idea and the concept here is if the hospital or the legal entity that owns the hospital is establishing the charges and collecting the payments for those physicians or non-physician practitioners, they should be disclosed through the price transparency requirements, because that's within the hospital's purview, and they have the discretion at establishing those charges, and they know what the contracted rates are. If it's not employed, they may not know what those charges are, they don't receive the payments, they don't have the information, and they can't report it. Interestingly, though, CMS has declined to define employment for these purposes. So there's no codified definition. What they did do is they did direct hospitals to look at the IRS definition of employee versus contractor, which is really that control test. So the bottom line here is if you have a W-2 relationship with your physician and non-physician practitioners, they should be included on your price transparency disclosures. If you have independent contractors and they have reassigned their right to bill to the hospital, I think that's more questionable. But if you think about the goal here, that does the hospital have control with the respect to establishing those charges and collecting the payment, if they've reassigned their right to bill to the hospital does have that So I would probably lean towards disclosing that, but I think that becomes a fact-specific analysis that you need to consider in each case. And if it's just a coverage agreement in which the physicians and the non-physician practitioners and their group are billing for the services directly, those would not be included in the price transparency. The next question is there a limit on the number of third-party payers that are reported? And the answer to that is no. Hospitals are required to include all payer-specific standard charges, i.e. the negotiated rates for all items and services. And this has come up because, especially with the initial implementation of price transparency, there was a lot of information, and it was a big lift to get this information out, especially during the pandemic when resources are scarce and continue to be scarce. So some hospitals did not include all payers. So if there were some that, you had one or two patients that were covered by that, or a couple items or services that were not charged for on a regular basis, they did not include those. As you're refining your price transparency disclosures, I do recommend that you go through and you include all payer-specific standard charges for all items and services. And the next question is, if the hospital does not have a standard charge for some items, for example, a gross charge for a service package, should it or can it report an average charge? And the answer to that is no. CMS has been asked this both in the Federal Register through notice and comment, and has commented on webinars. And what they've consistently stated is that average charges based on prior year's payments would not be acceptable because an average charge is not one of the defined standard charges that they finalized in the price transparency rule. And what they've said is they believe that the negotiated rate in those contracts with the payers is the most beneficial standard charge information for consumers to evaluate pricing information. CMS did provide some examples illustrating the use of NAs as an option. So for example, if you have a contract that pays you based on bundled services or service packages, so for example, using that appendectomy, they pay you one rate for the entire package of services for that appendectomy. Your charge master is not going to have a rate, or in most cases will not have a rate for an appendectomy. You're going to have all the individual line items that you're going to include on the claim form for that appendectomy, even though you're going to get paid a bundled payment rate. So when you include that appendectomy on your price transparency disclosure, under the gross charge, you wouldn't include an NA because you don't have a gross charge to that for that service. And then on the flip side, like if you have an aspirin, for example, on your charge master, you may not have a negotiated rate for an aspirin for some of your payers. So then under the negotiated rate for those payers, you would use NA. And then if you had the percentage, you'd include your gross charge times the percentage in the contract. So there are ways to get around that. Enforcement. Ben alluded to this, at the beginning of the presentation. CMS started enforcement pretty quickly on price transparency. And I think that was for a couple of reasons. One, it did have bipartisan support, both in Congress and at the executive branch. So there was a lot of buy-in, and this was really important initiative coming through the federal government. There are 3 levels of enforcement with respect to price transparency. The first is warning letters. The second is a corrective action plan. And third are the penalties. So for the warning letters, basically CMS is kind of looking through the websites. If they find non-compliance, they'll issue you a warning letter. We saw warning letters coming out 6 months after the effective date, which was January 1st, 2021. And so far, we understand, at least as of a couple months ago, there's been about 350 warning letters issued. I'm assuming it's gone up since then. Then if you don't correct it after getting the warning letter, CMS will request a corrective action plan. And they'll review the corrective action plan, make sure that it's adequate, and if so, they'll close that. So far, we understand that, again, at least as of a couple months ago, there were about 116 corrective action plans that have been requested, and 170 cases so far between the warning letters and the corrective action plan have been closed. The next level is the penalties. The penalties, when this first became effective, were about $300 per day for all hospitals. And some hospitals were very vocal and said, well, $300 per day, that's about $110,000 per year. We will pay the fine compared to how much this is going to take to implement. They did the cost benefit analysis, and the analysis said the fine was a lot cheaper. Congress and the executive branch heard that loud and clear. And what they did is they increased the fines because this was an important initiative. They wanted hospitals and hospital systems to comply with the price transparency rule. So what they did, January 1st, 2022, there's a sliding scale based on the bed count. So if you have up to 30 beds, it's still the $300 per day. But over those 30 beds, the penalty will increase $10 per day for each additional bed up to 550 beds. So the maximum is about $5,500 per day for each hospital. A full year of non-compliance will be $109,500 to just over 2 million. So that's a little bit more, in the penalty phase. So we saw more questions coming after that increase and more effort to comply with the price transparency rules. We have also seen CMS starting to issue those fines, and Ben is going to share some of that information with us.
Yeah, thank you, Lori. And that's right. I mean, reiterating Lori's point, the federal government very much was aware that some hospitals and some systems were kind of running a cost benefit analysis based on the initial penalties and making the decision to not attempt to comply, or at least not to attempt to fully comply with the federal price transparency requirements, and so they increased the penalties. And they have been moving forward with audits clearly, as we see in the warning letters. And most recently, just in June of this year, we saw our first two publicly posted financial penalties against hospitals for non-compliance. And that is one of the penalties. One aspect of the penalties is that not only are you financially penalized, but it is made public. So you can go out and see the actual warning letters and the ultimate, I should say, notice of financial penalties against these two hospitals. These were not Colorado hospitals. These were in a different part of the country. They were part of the same system, and one was fined just over $800,000 for noncompliance, and the other over $200,000. And based on the record, it seems pretty clear that these were two hospitals that had made the decision that they were not going to comply. And so some of the facts were fairly egregious in terms of they did not have a machine readable file actually posted, or at some point in the process, they actually removed a machine readable file with all their estimated or all their prices from their websites. And so a couple of takeaways from that process, I think, are: one, these hospitals did have a number of opportunities to come into compliance, and clearly, again, based on the record, decided not to take that approach, and so they ultimately were fined. I think in other cases, hospitals, when they receive those notices, do make efforts to comply with the rules and will have an opportunity to do so before they actually receive financial penalties. But two is that the federal government is certainly moving forward, kind of taking all of this to the next level, which is enforcement. And we're only going to see that continue over the next few months and next few years. There is no reason to believe that any of this is going to be rolled back. This has played out now over multiple administrations. It has played out regardless of who's in control of Congress. And I don't have any reason, and I don't think anybody in the industry should expect that any of this will roll back. And so a position of to take a position that you're not going to comply is certainly a difficult one to kind of understand at this point, given the financial penalties that are out there and that CMS is moving forward with audits and penalties. And then as we move into thinking about the Colorado law, I certainly don't think that these two hospitals could take this approach in Colorado. I think that would really cause some additional financial risk. So our second poll question here, I see is on the screen, so I hope all of you are seeing that as well. The question is, CMS has started auditing hospitals for compliance with the federal price transparency rule 2 or both. And I know we will give everybody a few seconds to get your answers in on those. Again, you need this for your continuing education credits. So please do hit a response on that. And
then while we're waiting on a couple of these to come in, I just wanted to let you know you're cutting in and out just a little bit in terms of sound. I don't know if it's from moving. Sometimes you're coming in perfectly clear, and then other times you're getting a little bit hard to hear. So, or I don't know if maybe something you might check if it's covering a speaker.
Yep. I will just double check on my end, but certainly let me know if that continues. So we're getting the results here on poll 2. Overwhelming answers are true. The CMS has started auditing on the federal price transparency rule, and that is the case. They have absolutely started auditing, and they will, I think, continue to do so. They don't get to a very large percentage of hospitals in those audits because these are, although maybe not easy audits for CMS to conduct, they are not as complicated as some other audits, including, for example, EMTALA violations, because here they're really desk audits. Someone within CMS can just go to a hospital website and see whether or not you're posting this information, and then use checklists to determine whether everything is there. And so I do think that they'll be able to get through a high percentage of hospitals over the next, again, few months and years. So hospitals should expect that at some point they will be audited by CMS for compliance, and that will certainly start. So now focusing on this new Colorado price transparency law. This was House Bill 2285 that was, again, effective just last week, August 10th. And that is for PPS hospitals. And there is a later effective date of February 15th, 2023 for critical access hospitals. Although, again, February 15th, 2023 is not that far away. So this will be effective for both PPS hospitals and CAUS here soon. What this law does is it limits the collection actions for hospitals that are not in material compliance with federal hospital price transparency rules. Those are the rules that Lori just went over. As you can see, there's quite a bit involved in there. We've been living with it now for almost 2 years, so hopefully hospitals that have been keeping up with this are close to, if not in full compliance. But if you're not, this new law is going to allow, what it does is it's going to prohibit you from taking certain collection actions. But then also, from an enforcement perspective, another thing that makes this law unique is that the government, the state government, is not going to enforce this law directly. Instead, it creates a right for patients to sue the hospital that was not in compliance with the federal price transparency law if certain conditions are met, and I'll talk about what those are. If the hospital loses in that suit, We'll talk more about the penalties, but essentially you have to refund anything you've gotten paid from the patient, also pay them amount equal to the service at issue, and then also attorney fees or other costs that they may have incurred as part of the process. And so essentially, not only are you not going to get paid for the services you provided, you're actually going to pay the patient the amount that those services cost. And then you could also have additional fees, including attorney fees, which could certainly become substantial in some cases. So why did Colorado do this? And it really is unprecedented. I am not aware of any other state that has enacted legislation that is similar to this Colorado law. And this is the text from the legislation itself. The General Assembly said that essentially this they felt was important to protect Colorado healthcare consumers from these types of collection actions taken by hospitals that are not in compliance with the federal price transparency law. And so clearly what was happening here is the Colorado General Assembly simply did not think that the federal penalties were acting as enough of a motivator to require hospitals in Colorado to comply with the federal law. That is, again, I said unprecedented in this context. It's actually very unusual, if not unprecedented in any context, not just hospital price transparency, to have a state come in and say, we are going to create a private right of action. We're going to allow citizens of our state to sue organizations in our state, in this case hospitals, because those hospitals aren't complying with a federal law. So it is a unique approach that the General Assembly has taken in these circumstances. One reason I think it maybe happened was we have seen a number of reports from some patient advocacy groups over the past year and a half that attempt to determine whether hospitals are in compliance with the federal rules or not. And one of those reports that came out earlier this year concluded that only 14% of hospitals across the nation were in full compliance. And in Colorado, that number was actually around 6%. Now, I've seen some of those reports. I certainly question the methods that they used in determining full compliance and would take issue at those percentages. But they have gotten a lot of publicity, and it wouldn't be surprising to hear that some members of the General Assembly saw similar reports and felt that this legislation was necessary. So again, the key aspect of the law is that it does not create any new price transparency obligations. It only increases your risk if you're not currently complying with the federal hospital price transparency rule that Lori talked about in detail. So if you are a hospital that feels that today your hospital is fully compliant with the federal law or very close to it, this law would have very minimal, if any, impact on your organization. If, however, you are a hospital that, as we talked about, had at some point taken this cost-benefit analysis and decided that you were not going to comply with the federal law, or you were unaware of it, which we have seen come up, given that we're in the middle, or we're hopefully not in the middle, we're in a continuing public health emergency and focus has understandably been elsewhere. This would be a game changer. This would have a potentially huge impact on those hospitals that are what I would view as almost 100% non-compliant. You have made no efforts to comply with the federal law. Then this is a really big deal when you start to think about how it limits your right to get paid for the services that you're providing to your community. So you can break it down. It's not a lengthy or overly complex law. It's really got two parts that I mentioned. The first part is the prohibition, what you cannot do. If you are non-compliant with the federal law, you cannot take certain collection actions. Those are outlined in the legislation. I've included or summarized them here. Essentially, you cannot refer to, sell, or transfer a debt, a patient's debt, to an outside collection agency or debt collector. And then you also cannot sue directly. You can't sue the patient or enforce through arbitration or a mediation clause that you maybe had any outstanding payments due from the patient. And then finally, you can't cause a report. This really just goes on with the first two. You can't cause a report to be made to a consumer reporting agency. The second part is this patient right to sue. So there's a prohibition, and then what happens if you violate the prohibition? Well, it opens up the right to the patient to sue the hospital. So I do want to clarify or point out that that doesn't prohibit all activities. Very importantly, you can still bill the patient. You can still bill the third-party payer, just like you normally would for items or services, even if you're not in compliance with the federal hospital price transparency rule. It does not limit you or prohibit you from billing a patient or their third-party payer. It does prohibit you, though, from going that next step that might be part of your normal collection process or activities and moving it to an outside collection agency or suing the patient. So it severely limits kind of how you attempt to get paid. And it's not that difficult to imagine a scenario where if patients are aware of this law and a hospital is not in compliance, and it's kind of obvious the hospital is not in compliance with federal price transparency rule, meaning you're not even posting your machine readable files, that patients would just ignore the bills because they know you can only take it so far, and there's really no recourse at that point, and certainly not the normal recourse that you'd maybe take. So just a little bit more on the patient right to sue. First of all, it only comes up if a non-compliant hospital, and again, non-compliant with the federal price transparency rule, takes any of the prohibited collection actions. So that triggers the right for a patient to sue. The other important part about this is the non-compliance must be, quote, material, and maybe more important than this materiality standard, which will just have to get played out in courts to the extent that these suits are actually brought. The non-compliance has to be related to the items or services charged to the patient. That's important. For example, a community member who's not even a patient of the hospital cannot sue the hospital because you're not complying with the federal price transparency rule. They wouldn't meet the requirements to bring that suit. Also, if I go to a hospital and have a knee replacement surgery, and then I learn that the hospital failed to publicly post their negotiated rates for a certain unrelated imaging, I can't sue under this law because of the hospital's failure to post the CT scan prices, because I didn't receive a CT scan. I can only sue if the hospital's non-compliance is related to the item or service that I received. So there's some factual questions that will have to be established in a lawsuit. But again, I look at the scenarios of a hospital that is not complying at all with the federal law. And that's where I think certainly the biggest risk is, because in that case, it's not going to be difficult for the patient to show that there was material non-compliance with the items or services that that patient receives from the hospital. Finally, penalties and damages. I mentioned this earlier. Oh, and I see a third poll came up, so I guess I'll let you all kind of take a look at that poll that asks, does the new Colorado law allows non-patients to sue a hospital if the hospital is not complying with the federal price transparency rule? True or false? And as we're answering that, I'll just cover on the last slide here. That's penalties, which I've already alluded to. If a hospital is sued and loses, then they must do a few things. First of all, they have to refund to the patient any amount that they received on those charges that were at issue. In addition, they have to pay a penalty to the patient in an amount equal to the total amount of the debt. So again, if you have a patient who had a $20,000 service and it turns out they are successful in the lawsuit under this law, not only do you have to refund anything that they paid, but you actually have to pay them $20,000. And then you would also be responsible in those cases for paying your attorney fees and any associated sustained costs related to defending, for example, your collection activities. And then finally, if you happen to have caused or directly reported this to a patient, a credit reporting agency, you would have to make steps to remove that from their credit report. So those are the penalties. I'm just looking to see, I believe we've got just a couple minutes left here, and we do have one question in here. Lori, this might be as much a question for you, but I will read it. The question is, how often do hospitals have to update the machine readable file, the charge master that's posted on the website? And they note in the question that this hospital creates new codes frequently and updates pricing kind of on an ongoing basis. So how often do hospitals have to update that machine readable file?
My recollection is that you have to update them once a year. CMS, there was a question about that in the Federal Register, and CMS did acknowledge that some hospitals do update their prices more frequently than once a year, but they weighed the cost benefit analysis and went with the once a year.
Yeah, I kind of remember that back and forth in that commentary as well, because some commenters had asked if the hospitals were required to do it on a rolling basis, and to CMS's credit on that question, at least they recognized what a huge administrative burden that would be to try to keep that updated on a real-time basis or even a monthly basis. So they went with the 1 year period.
Yep.
So I don't see any other questions in the chat or Q&A. Again, certainly if there are questions after the presentation or for folks who are listening on demand, you have our contact information. Please reach out to us with any questions. And with that, I'll just say thank you to everyone for joining us.
Thank you so much, Ben and Lori, for sharing your expertise with us today. We really appreciate it. A reminder, right now, the presentation is available in that chat box if you want to go ahead and download that. I will also follow up in the next day or two with a link to the recording of this as well as to the slides. So you will have those available. Your CPE certificates will be sent out once attendance and participation has been verified. And I do just want to remind everyone who's on that our fall summit is coming up in September 22nd to the 23rd. That's going to be held at the Delta in North Glen. So we really look forward to seeing you all there. We have a great program lined up. Ben's going to be, and Lori, I believe, are going to be talking to us again and probably giving us a lot of more detail on some of the price transparency and some additional things. So we look forward to seeing you guys again then. But go to our website, hfma-co.org, to find out more about that event. We look forward to seeing you all soon again. That concludes everything for today. Thank you all for sharing your lunch hour with us.